And thanks very much for the invitation to speak. I was bad and didn't submit a bio, so that's why that was a bit brief. But I guess my involvement with malaria started about 10 years ago when I became involved in the Malaria Human Challenge model that we set up at QIMR under James McCarthy, where we inoculate healthy volunteers with malaria, mainly to test new drugs. So I'll touch on that a little bit in my presentation. So this is what I was going to talk about. Some basics, a bit about where the vector and the disease is at the moment, some stats both locally and more broadly, focus fairly heavily on some of the clinical aspects of malaria, talk about how malaria is travelling more broadly as well, and then hopefully wrap up within time. So a lot of this stuff most people will know. It's a protozoan parasite of the genus Plasmodium, and for a very long time we were confident there were 4 species that were relevant to and infected humans. They're listed there. Recently we've increasingly recognised the significance of Nolzii, which is the Malaysian monkey malaria, and more recent reports that simian is probably also relevant for humans, although at a far lesser degree. And if you are going to fall asleep after this, just try and take this one slide on board, because I've tried to summarise what I think are the key points in one quick slide. So if you're going to remember anything, P. falciparum is the bad one and needs to be taken very seriously, causes the most deaths, and really is a medical emergency if someone's diagnosed with this. Vivax, again, to take one thing away from that, is that it can come back. People debate the maximum time that it can come back. It's probably out to even 3 or 4 years. And is the most common type of malaria that we see. And then Nolzii, as I said, is the Malaysian monkey malaria, which was thought to not be all that bad, but really its pathogenicity is increasingly recognised. It's probably a bit similar to P. malariae, but still thankfully fairly geographically isolated. So you can't do a talk on one of these parasites without an obligatory CDC life cycle, but I think this one's a bit complicated. So we kind of rejigged one a few years ago, and I guess the key take-home messages without focusing on it too much is it's a very complicated infection with many different elements to its life cycle, which is why we really need better treatment, because at the moment the treatment that we have really just targets the blood stage part. So that makes you feel a bit better and gives you a clinical cure, but we don't get rid of the hypnozoites in the liver, nor do we render people non-infectious, which is part of the big problems with malaria and why there's so much work on new treatments that hopefully will do all of that, and hopefully in a single tablet rather than having to give 3 days of therapy. Most people probably know it's mosquito-borne, and it's the Anopheles mosquito, which is the one responsible for this, and transmission occurs via the females. And there's quite a complex vector environmental interaction here which determines the geographical spread and the prevalence of malaria. So to be able to transmit, the mosquitoes have to stay alive long enough for the parasites to develop to the stage they can infect. And this is shorter in warmer temperatures, which is why the chance of transmission is greater if it's a bit warmer. But also different Anopheles species vary in their ability to transmit malaria, and I'll show a slide on where that's distributed. So you can see just how many there are by all the different colours there. And interestingly, if you look down the bottom, I don't know how well it projects, but there is one that's present in the tip of Australia. It's regressed over time to be fairly restricted just to the top, but is potentially coming back down. So we do potentially have a vector that could transmit in Australia if people bring back malaria. It's a very complex disease, is certainly associated with poverty, and unfortunately disproportionately affects poorer people. That then is a bit of a self-fulfilling cycle, because those people are unable to work and are sick, so they become more impoverished and so therefore more susceptible to the disease as well. And in terms of the distribution, it's basically a very broad band around the equator, such that about half the world's population is at risk of malaria at any one stage. And this distribution is determined by many factors, so a lot of things to do with the vector, including fresh water for breeding, rainfall, humidity, as well as ambient temperature. So as I said, it's quite complicated. And this is the disease distribution. There's a group, the MAP project out of UK, and you can see that it's quite a broad band right around the middle of the world there. In terms of our local statistics, and I must go to different barbecues and Chris, because no one tends to ask me how much malaria we have in Australia at any one time, but it's not that much, so a lot less than TB. So, and again, our reports are about the same sort of lag there. So in 2013-14, less than 400 cases in Australia, which was a significant decrease over the mean of the previous 5 years. And we haven't had any locally acquired malaria in Australia. There has been a few outbreaks since malaria was eradicated in 1982. So really only 2 or 3 cases of local transmission after people brought malaria back to Australia. And you can see that graphically that really our number of notifications has had a steady decline, which is good. And again, I think the shadowing hasn't really come through very well. But in terms of looking at where people have come from and month of diagnosis, there does tend to be a bit of a spike over our summer. So December, January and February have the highest peaks there. And it's kind of the red bars that are the most prevalent, which is other. So you can see that there's not really one country where people are reporting malaria from. There's quite a big distribution. And if you look at population, so age and sex of people that we're diagnosing with malaria, and again, there's a lot of complex factors that undermine this graph, but it's 25 to 29-year-old males who are the commonest demographic to be diagnosed with malaria in Australia. But you can see these peaks go all the way out to extremes of age and do involve both sexes, so it's not something that can be discounted just on these demographics. In terms of the worldwide statistics, so in 2016, so the WHO do a really good malaria report every year. It's very extensive, but they do a little summary at the start. So in 2016, so over 200 million cases, so astronomical when you think of those numbers, in 91 countries. And a little bit alarmingly, this is a slight increase over the previous year, and I'll touch on the global trends towards the end. Deaths, fortunately, has continued to decline, so about 450,000 deaths, which is about the same, if not a slight reduction compared to the year before. And if we look at where most of those come from, so around 90% of both of those cases, and as well as deaths, are from the African region, and the majority of deaths, very unfortunately, are in children less than 5 years of age. So the statistic that's often quoted is that equates to a child in Africa, unfortunately, succumbing of malaria about every 1.5 minutes. And about 5 years ago, that was about every 30 seconds. So that is a reduction, which is good, but obviously there's a lot of work still to be done. If you look at regions, and unfortunately the formatting's gone very awry with this slide. So this is cases, breaking up into Falciparum and Vivax by region. You can see the vast majority are cases of Falciparum from Africa. The next one is Southeast Asia, where it's about 2/3 Falciparum, 1/3 Vivax. Eastern Mediterranean, almost 50-50, and then Western Pacific and the Americas account for some, but obviously a lot less of the cases. So moving on to the clinical aspects. So I guess the main thing with malaria is there's no real way of excluding it clinically. So if someone has a fever and travel to an area where malaria is endemic, which is that big broad band around the equator, it really needs to be considered and considered quickly. So there's nothing specific that will make you be able to rule this in or out on history or examination. And there's a lot of variables that determine how people respond to an infection with malaria, so which type of malaria, which is pretty obvious, but also their immunity, so how long from, if they have come from a high endemicity country, how long ago that was, how old they are, if they've had any prophylaxis and how much of it, if they weren't compliant, whether they've had partial treatment or not, how long ago the exposure was. So there's so many factors that determine how people respond to malaria. And the highest risk really is people who are young children or pregnant women. Incubation period is also highly variable, so from maybe 10 days or so, typically, and again dependent entirely on the species, out to about a month after inoculation. But with Vivax particularly, the reactivation can come many years after exposure, even out to potentially 4 years. So the manifestation, so fever is the one common theme here, but really it can look like anything. So gastroenteritis, acute abdomen, pneumonia, even meningoencephalitis. The initial symptoms are typically fairly non-specific, and different people will get these at different rates. So some fairly obvious things there. Headache does seem to be a really strong feature. So I said we've inoculated over 300 people now with our model, and nearly all of them have had a headache as one of their first signs. But even a cough and things that you wouldn't normally associate with malaria can be a presenting symptom. And often there's really not much to find on examination, perhaps splenomegaly or signs of anaemia, particularly if it's a bit late, but often there's not too many things that specifically point to malaria. And as a lot of people know, and as I said at the start, falciparum can be severe, and unfortunately people can go from being a little bit febrile and maybe with a few aches and pains to being really sick with falciparum in a really short space of time. And there's a number of factors there, but mainly because it has the highest parasite numbers, but also those little parasites get stuck in lots of end organs, which is why it can affect basically every organ, particularly the brain, but also the spleen and anything else really. And there's this table here which shows the signs or symptoms and other features of severe malaria, which most of those are pretty straightforward, but you can see that it can affect anything, and if you do get to that stage with any of those, it really is something that needs to be treated seriously. In terms of the diagnosis, we have two main methods, and these haven't really evolved all that much in quite a while, so we still rely on microscopy. And one of the problems with living in a really low endemicity area like Australia is that people aren't used to seeing these with a lot of regularity, so perhaps here compared to places where there might be a lot more, the sensitivity is a little bit less. So we also have antigen-based tests, so these get called a lot of things in a picture down the bottom of the slide there, but rapid diagnostic tests. But just think of these essentially as a pregnancy test for malaria antigens. So this is something that a little drop of blood can be put on and you get an answer very quickly just by comparing the little lines. But these days, like a lot of fields of microbiology, our diagnostics have evolved, and we do actually have a PCR available. So this is a molecular test where we amplify up some of the genetic material of the parasites. And until fairly recently, this was a research tool predominantly. But both Pathology Queensland and Sullivan Nicolaides, as local examples, have this readily available now, and it's particularly useful for really low parasite counts, maybe people that are partially prophylaxed or partially treated. People that might have mixed infections, the implications there might be that we see the falciparum but want to make sure there's Vivax or not to know whether to get rid of the sleeping parasites in the liver. So this is something that can also be requested as well. The differentials are pretty broad, so basically any febrile illness that people might pick up while travelling, but there are a few key points that might help a little bit. Dengue and myalgia tends to be worse than malaria, and they do tend to have that rash, which all the textbooks have that same poor person with a big handprint on their chest because it looks like sunburn in non-sun exposed areas and goes away with pressure. Chikungunya tends to be a bit milder and also has a bit of a rash. Meningitis can look very similar to dengue, but usually they don't have the other things that you'd associate with meningitis like neck stiffness and photophobia. Even pneumonia can be in the differential list, but usually you've got some local signs and symptoms there that help to a degree. Sepsis, so it's important not to forget and get your blood cultures as well. Typhoid can look very similar, even lepto, and I guess something that poses a lot of problems, particularly a few years ago when we were talking a lot about Ebola, is the viral hemorrhagic fevers can look a bit similar. And I guess this is bad in both directions, so when we're worried about Ebola, we don't want to miss malaria because it's so prevalent and probably the thing that's more likely. But also, I guess we don't want to assume that it's malaria and miss a hemorrhagic fever if we were unlucky enough to get one of those. So something that's got to be considered if the clinical presentation's right. So like I said, with management, it is something that does need to be handled seriously. I remember working as a registrar at Sullivan Nicolaides, and very commonly we'd get smears or film sent in towards the end of the day that would be positive, and at 8 o'clock we'd be ringing the GP, couldn't get hold of them, wouldn't have a number for the patient. So at least half a dozen times we sent police and ambulance around to people's houses who were tested positive for malaria, and we couldn't get hold of the requester. So if this is something that's on the differential, it's important to make sure that someone follows the test up in a timely manner, particularly if it's falciparum, but really with any of the malarias that you're looking for. I'd also have a low threshold to get expert advice. So a lot of the guidelines will say that ID need to be involved. That's particularly relevant for falciparum, but we're always happy to be involved for any malaria, particularly if people are unwell. And even if you suspect it and haven't yet confirmed it, it's also something we're happy to be involved in. The treatment's been simplified a little bit because of increasing resistance, so just like TB and a lot of these other pathogens, we've got a lot of troubles with resistance in malaria. So really the artemisinin combination therapy, which is what that ACT acronym stands for, which is artemether and lumefantrine, so the brand name here is Riomet. That does get called different things in other countries, so a lot of people know that as Coartem. We would use that essentially for every case of malaria now. So gone are the days of looking to see where people have come from, whether we might be able to use chloroquine. There are some very rare examples of where chloroquine might still work, but we basically assume chloroquine resistance unless you've got expert advice to the contrary. And then, like I said before, hypnozoites, so the sleeping parasites, particularly with Vivax, need to be eradicated, and we use something called primaquine with that. I think Chris has given me his thing already. A lot of people might have heard recently that the first new malaria treatment to be licensed in a very long time is tafenoquine, which is basically like primaquine that's a bit better. It was originally thought that it might get rid of the need for testing for G6PD, but it doesn't, unfortunately. So exactly how we use that is still yet to be fully elucidated. But the key with primaquine is that you need to check that G6PD, because if you give it to someone who's deficient in that enzyme, they can have life-threatening hemolysis. And the other, practice point that a lot of people forget is a lot of the books say 30 milligrams a day, but it's really the total cumulative weight-based dose that's important. So that 30 milligrams daily for 14 days works if someone's 70 kilograms, which unfortunately few of our patients are these days. So if someone is heavier than that, you need to do weight-based dosing, otherwise they can relapse again. I saw someone not 2 weeks ago who got 30 milligrams a day and he was 110 kilograms and he had a second relapse of Vivax. And for severe malaria, obviously handled in a high acuity setting, we use IV artesunate. So the ACID refugee guidelines have got some points about refugees there. So everyone coming in is offered the departure health check, which does include an RDT for malaria and treatment if it's positive. But it's still thought advisable that everyone, once arrived in Australia, should be investigated for malaria, even if they're well within 3 months of arrival, or if they have any febrile illness within 12 months, they need to be investigated as well, regardless of what the thought is and what they had before they left. The recommendation is for both thick and thin films and a rapid diagnostic test, because the RDT is thought to not be sensitive enough, but as I said, a good indication potentially for PCR if we're worried someone might have a low parasitemia. Their guidelines recommend everyone with malaria should be treated in consultation with or by an ID physician. And I know that a lot of people are very experienced in treating malaria. That might not always be the case, but certainly the offer's there. And everyone with falciparum needs to be admitted to hospital, and that's certainly the case. This is the top 20 current countries of origin for refugees and recommendations for malaria screening. And you can see most of them there do have a yes to malaria, which is that first column. A lot of people in this audience are going to be way too familiar with this already, but the population we have a lot of trouble with malaria is people that are visiting friends and relatives. And this is for a host of reasons. I guess the main thing that's relevant with malaria is people's immunity to malaria wanes very quickly when they leave a high endemicity area, within months probably. And those people that having spent some time in a low endemicity area who return to somewhere with a higher prevalence often don't regard themselves as being at risk. And I've got some slides on prevention, but they often don't go and do all those things. So therefore a very high risk of reacquiring malaria and in many ways being sicker than they were when they may have had it before they left because of that immunity that's decreased. In terms of prevention, I always find this a bit tricky to know exactly where to look for who to give what sort of prevention to. So this fellow from America, David Friedman, wrote a really good article in the New England Journal a little while ago now, but it still holds true. And I'll talk about some of the features, particularly around the chemoprophylaxis on the next slide. But that paper, as well as a lot of the other sources of literature, recommend that obviously vector avoidance is the best way of not getting malaria, even better than chemoprophylaxis potentially. And some of those things are staying inside at dusk and dawn where that mosquito activity is the greatest, physical barriers such as long sleeves, pants, insecticide-treated bed nets, keeping windows closed, particularly at night, and a repellent-complaining DEET, but of the appropriate strength. So it's got to be 30 to 50% or greater, and the brand that a lot of people know of in Australia is Bushman's, and it's also important to reapply that, and a lot of the guidelines will say every 4 to 6 hours. And I guess the other feature is if you're seeing someone who's particularly high risk, and really pregnancy is the feature that this might apply to. If someone's pregnant and potentially travelling to somewhere with high prevalence of malaria, if it's non-essential travel, certainly discouraging them travelling while pregnant would be something that I'd at least try to do if at all possible. So that paper has a lot of stuff on who to give what chemoprophylaxis to that I've kind of summarised in this table. So just to go through that very quickly, so Malaria is probably the best, with the biggest problem there is that it's expensive. So this is something that you give daily, only need to start the day before they go and for 7 days after. Can use it in kids who are greater than 11 kilograms, not in pregnancy. And it's the best tolerated, which is the best feature. And in terms of resistance to some of the other ones, this one is probably in some ways the most effective. But as I said, it's quite costly, so that's often prohibitive. Mefloquine is one that a lot of people cringe at when you say the word. It's copped a lot of really bad press. It's probably not as bad as some of the reports will make out, but has become very unpopular. This is weekly and does need to be started. A lot of the guidelines will say 3 weeks before. 1 to 2 is probably okay, but wouldn't be recommended, and kept going for 4 weeks after. And if you go right to the right-hand column, the neuropsychiatric issues, something that a lot of people know about. Doxycycline is probably the most popular because it's very accessible and very cheap. It's also daily, short duration before, but a relatively long duration post. And I guess this is where we see the problems, because people come back and they might take it for a couple of days, but you really do need to complete that 4 weeks after. And people do need to be warned about the side effects, because I find it's much better tolerated if people are aware of the photosensitivity and their gastritis or reflux issues, but if they don't know about it, it causes problems. Chloroquine we don't tend to recommend so much, and primaquine, again, not so much for prophylaxis. So, as I said, that article has all these things in a slightly more detailed way, but I thought it was good to summarise quickly. So, in terms of the overall progress of malaria, the trends in incidence globally and by region, you can see that at the start of this decade there was a significant reduction, but unfortunately a lot of these graphs, depending on region, seem to have plateaued out in recent times. So some big gains were made, and I'll touch on some of these, but it does tend to be plateauing, which is a bit of a concern. And mortality has followed a similar trend, both globally and in these regions, with some reductions, sort of 2010 to 2012, but really it's stabilised, which is unfortunate more recently. So the things that probably made an impact on malaria broadly, so access to those tests that I mentioned, so significant increase in those, sort of 2010, 2011, access to that combination therapy, so the artemisinin combination therapy went up significantly at the start of the decade. Increased distribution of bed nets and indoor residual spraying, so vector control measures. And so we saw some significant gains in mortality, meaning that millions of deaths have been averted because of these measures. And a lot of people know about this because there's been some very prominent figures behind all these things, like the Gates Foundation, for example. So these were all really big gains that we had in terms of controlling malaria. And then we had a vaccine as well. So a lot of people ask, do we have a vaccine? So the right answer to that is yes, but is it good and is it available? Well, probably not. So a lot of effort was and money was invested in this RTSS vaccine, which has got the brand name Mosquirix, which is an antigen from the parasite fused to Hep B surface antigen. And so this, in theory, should stop the parasite invading hepatocytes. So GSK sort of bought into that, but really, again, Gates Foundation funded a lot of it. And it's probably, the books will say 5 to 10 years ahead of other vaccine candidates, but probably a lot more. And some early data said it probably worked about half the time, which sounded pretty good. But as more data comes out, it's probably more like a third or even 25% of the time. So is it good to have 25% protection in vulnerable groups from malaria, at least for a period of time? It probably is. But I guess there's some things that we still don't know, is how long it's going to last, how many times we need boosters. So at the moment, some kids in some parts of the world are getting 4 injections from this. And then there's a lot of complex host parasite dynamics that are still being looked at. This was approved by the EMA a couple of years ago, so it is the world's first licensed malaria vaccine, but we're really yet to see how it will play out in terms of impact on a broader scale. The challenges, though, so as I said, a lot of those figures have plateaued recently. So while we saw big gains in the distribution of nets, that's really gone backwards in recent times. Indoor residual spraying, again, has plateaued a little bit, but the resistance thing has come out that not only is the pathogen resistant, but we have vectors that are becoming increasingly resistant to the insecticides we're using. And in some places, we have vectors that are resistant to all of the major insecticide classes available. And again, sorry about the formatting, the pictures have all moved around, but there's quite significant issues with resistance of the parasite. So 4 Southeast Asian countries, and I'll show a map about that in a second. So that obviously caused a great deal of concern. We first started reporting parasites that were resistant, such that made the front cover of The Lancet, because at that stage we really didn't have anything coming through behind the drugs that we had, and we were worried that this was going to cause huge problems. This started as a fairly geographically isolated area on the Thai-Cambodian border, which got called the epicentre of drug-resistant malaria, but we are seeing issues with drug resistance spreading more broadly now. And it's not that there's not new drugs around, so again, not expecting you to read these. These are the Medicines for Malaria venture, which is sort of the Bill Gates arm of malaria drug development. This is their list at the moment of drugs at varying stages of development. So you can see there's lots on there, but I guess the like a lot of antibiotic development, it's quite hard to get these drugs out there for all of these reasons. So it's really hard to do trials where people get endemic malaria. These people often have a lot of other issues that make it hard to do clinical trials on them, including co-infections, reinfections, a lot of other issues. And it's simply hard to do clinical research out there because of all of these reasons, which is why we've created a local malaria epidemic at QIMR, where we took parasites from someone who returned with malaria and we inoculate these into healthy volunteers to trial all those new drugs, so we can hopefully expedite the development of new interventions for malaria, so we can hopefully get what we'd really like, which is a single tablet that is taken just once that not only gets rid of the blood stage, but also renders people non-infectious. And that's just a bit of a picture about how we do that. So that's the donor, we collect the blood and then we give it to people and we feed mosquitoes on them. So it all sounds pretty nasty, but it actually, we do this under very controlled conditions, and it has really helped us progress some of those new drugs. So if anyone wants to give that a go and see what malaria is like, you can get on our Facebook. So just to wrap up, so we've obviously had some big gains in malaria a few years ago, but those have plateaued, which is a bit concerning, and so there's many challenges still remaining. So malaria is certainly something that we still need to have a very low threshold to consider in anyone who returns from an endemic area with a fever and anything else. But I guess prevention is better than cure, so if you can catch people that are going to areas with lots of malaria before they go and advise them on vector avoidance measures as well as prophylaxis and avoid them getting malaria, that would be the best way to deal with that. And in terms of treatment, at this stage we've got these artemisinin combination therapy, so Riomet for now, but that's going to evolve fairly quickly. Some references, and I've got my details there, and I'm happy to take any questions.
Sorry, this is a little bit off track, but DDT spraying in South Africa, they've recently taken that on again and finding it to be a lot more effective. Is that being used in other parts of the world now as well?
I believe so. So there's a lot of places that are having issues with insecticide resistance, so I think that and other insecticides are being brought back out to use more widely. And a little bit like the drug treatment, there's a need for new insecticides, and so a lot of development there. But yes, it has happened in a few places because of that reason.
There was a lady on the radio this morning talking about vaccine development. Was it QIMR or maybe QUT?
That was
a whole species factor.
Yeah.
It's interesting.
So that was probably Danielle Stanisic, who we work with. She's at Griffith on the Gold Coast, and Michael Good is the head of that group. And they've got a novel approach to vaccine development where they have live attenuated parasites, so it's very complex. There's a lot of malaria vaccine development underway at the moment. There's lots of groups trying to work really hard, but just the complexity of the life cycle and knowing which stage to try and vaccinate people against. Personally, there's a group of people working on transmission blocking vaccines so that people might be able to get malaria but then will not be able to pass it on, and I think there's a lot of scope for that to be something that's taken forward, but and that's something we've done a little bit of work on peripherally. So there's a lot of vaccine development out there, but it's still a long way before we get something that's probably where it needs to be. And I guess the main thing is if you're worried someone might have malaria, we're always happy to be involved early because it can be bad. Thank you.
Thank you. So actually, before you move on, I also have a question.
Sure.
So, because we have had in a number of locations across Queensland this year some newly arrived refugees who've screened positive with a rapid test offshore in their departure health check that you mentioned. So what would you recommend in terms of testing and treatment once they arrive in Australia? When should it be done? Who should do it? Where should it be done? And who do we talk to?
Oh, good question. I mean, I think if you're in any way concerned, I would have a really low threshold just for testing and then if positive, treating. Trouble with some parts of the world is there's a whole lot of issues with maybe not getting the full course of treatment, or maybe even getting substandard or low concentration medication. So I think unless you're really confident that they're completely well and have had a full course of treatment, I would certainly redo the test and treat them if positive. And I think that's what the ACID guidelines are getting at, that even if someone's quite well, and even if you think they were tested and treated before, I would redo the test in the first 3 months ideally. But if they're febrile, the ACID guidelines will say out to a year, but I think if anyone's febrile and has come from anywhere with malaria in the past 3 or 4 years, I would still do the test as well. The test isn't expensive, so and it's quite quick. So, the films and the RDT, and the antigen-based test. So I'd have a really low threshold for doing those in anyone basically febrile who's been in one of those areas in the past 3 or 4 years.
And if you're doing thick and thin films, do they need to be done at specific intervals? Are you not bothered about intervals?
Yeah, so good question. So everyone is aware of the periodic fevers with malaria, and sometimes you do need to do more than one. So if someone's febrile, I would do at least 2 lots. And ideally one of those would be at the time of a fever, if you can. That can be difficult, obviously, but if someone gives you a history of fevers and they come in, they're not febrile when you see them, I mean, I would do one straight away and then try and give them a form for another one to get either the next day, or if they can get to somewhere that can do that while they're febrile, that would be ideal. But as I said, I'd do at least 2 in that case.
Thank you very much.
Thanks.